Good evening, everyone. My name is Maggie, and I'm with Capital Health. And I just want to go over a few ground rules before we start. Should any technical difficulties occur, we appreciate your patience and understanding as we work to quickly address them. We ask everybody to mute your microphones to help keep the background noise to a minimum. And when we're doing questions, you can unmute your microphone, but then please mute it again. Remember that private chat is never fully private, so just be aware of what you write in the chat box. At the end of the lecture, we ask that you fill out a survey. It is attached in the chat box, and I will put it there again. And we ask that you hold your questions until the end. You can either type your questions in the chat box or you can ask them of the speaker. So I'd like to introduce Kathie Olson. Kathie Olson is an advanced practice nurse clinically focusing on bladder and pelvic health issues. This has been her passion for 30 years. She's trained to assess, diagnose, and treat both urinary and gynecological issues. Kathie is clinical coordinator of the Capital Health Center for Incontinence and Pelvic Health, a multidisciplinary program that helps people with complex bladder and pelvic health. The center assists patients and referring physicians with a wide range of resources for diagnosis and treatment, including a team of behavioral health, colorectal surgery, gynecology, physical therapy, and urology specialties. So I'd like to welcome Kathie.
There we go. Can everybody hear me? So I am so excited to be here tonight. I hope the next time that I do one of these programs, it will actually be in person. So tonight we're going to talk about, is your bladder controlling your life? And the goal is to understand more about overactive bladder. So just a quick review, the services. So I work at Capital Health, the Center for Incontinence and Pelvic Health. And I work with individuals with a variety of issues, such as leakage of urine or urinary incontinence. Tonight, we're going to focus on the second area here, this urinary frequency, urgency, and overactive bladder. Realize too, at the center, we deal with patients that have issues with their flow, or maybe feeling like they're not emptying, but they are. That's called avoiding dysfunction. We also help individuals with bowel issues, such as leakage or feeling of incomplete emptying. Another group of individuals that we work with are women that have prolapse of either the vaginal walls or the uterus. We also work to help women with intimacy, chronic vulvar itching issues, and the final thing is some urinary tract infections or recurrent symptoms, or something also called interstitial cystitis. And we will briefly, I will try to bring that up again tonight a little bit, that interstitial cystitis and what that is. So many times when I work with patients, I hear a variety of issues that they notice that may be happening. And one of the things is that they can't go anywhere without knowing where the bathroom is. I had a patient today who said she just couldn't go to the park anymore because she was really having that inability to go anywhere, because if there wasn't a bathroom, it wasn't an option. Many patients come in and say, I just want to have control back. It's so frustrating. They feel like if they could just have a better sense of what's going on with their bladder, they would be able to get their life back. And also many individuals state, my bladder limits what I can do. It's interesting that the statistics are so high that 40% of women have urinary frequency urgency with or without leakage. And they know where all the bathrooms are in town. There actually has been a book published to tell people where all the bathrooms are. And when you're talking about individuals over 65, 40% of those individuals can have frequency and urgency, but they also can have leakage. And as women and men get older, this leakage or urgency and frequency to go to the bathroom increases the risks of falling and being placed in a nursing home. So what we're going to do tonight is we're going to talk about everything you ever wanted to know about your bladder but was afraid to ask. So my goals for tonight's discussion is I want to clarify why it's important to see a healthcare provider for this. So many people tell me that I've been told I have a peanut bladder and I just need to live with it. Or I talked to my doctor about it and They just said it's just a little inconvenience. However, when your bladder is controlling your life, it's more than an inconvenience. What is this frequency, urgency, with or without leakage? Is there a name for it? Understand how your bladder is supposed to work. What is normal? Because many people have a misconception of what normal is. And then the final thing we're going to do tonight is discuss effective treatment options for this issue. I want you to make sure that you remember that you don't just have to live with this frequency and urgency with or without leakage. And today is really your opportunity to build the tomorrow you want in regards to your bladder. When I had a patient, the same patient who told me she couldn't go to the park anymore. I had seen her previously, and she was in for a follow-up, and she had achieved her goals. And when she said to me that she could go to the park again, or she could take her grandchildren out and do activities and not worrying about the bathroom. So I want everyone to know that you don't just have to live with this. So why do people just live with it? Well, sometimes it's because they're afraid of treatment, or that they're just not sure of the treatments. They've maybe tried a medication, or they don't want to go on the medication because they've heard of the side effects. So they think that's the only thing that's out there. Sometimes it's time constraints, because when you talk to providers about the different options, it gets a little overwhelming about all the different things, or maybe to come back for multiple visits, and people feel that they don't have the time to do that. But the thing I find that happens the most is that they're not asked about it and not educated that there are things we can do to help you. And you're going to find out tonight, sometimes it's just really simple things that can make a huge difference. So again, why should you see a healthcare provider? Well, I believe everyone should be evaluated. The first reason is because there are other things that can cause this frequency and urgency and leakage. Sometimes it's something like diabetes. I've identified many individuals with diabetes that they didn't even realize they had it. Because when you have diabetes, you can have increased frequency and urgency to go to the bathroom. You can get recurrent urinary tract infections, and it's all because of the sugar issue. Individuals can come in and they may think they have just frequency and urgency, but they may have a urinary tract infection or a bladder infection. For women that are postmenopausal, it can be because of a lack of vaginal estrogen. For gentlemen, it can be because of prostate issues. It can be the most severe thing is bladder cancer. So we want to make sure that overall you're healthy. When we talk about seeing a healthcare provider, what's going to happen to you? Many people are afraid of, oh my goodness, they're going to do all of these terrible tests when I come in. What's going to happen? Well, the underlying thing is that we need to determine the cause of the problem. So we need to rule out those other issues that may be happening. So we want to get a history of your symptoms. What's going on? How many times do you go to the bathroom? How many times do you go at night? Do you have leakage? Do you have urgency, frequency? Do you leak on the way to the bathroom? Do you leak when you cough, you sneeze, you laugh? Do you have pain when your bladder fills? Things like that we're going to ask. We also will do a urine test. Everybody who comes in to see us, we want to make sure that you don't have an infection, that you don't have blood in your urine, that you don't have sugar in your urine. The next thing that should happen is we're going to do an exam. And so it's really important for female patients that you have an exam looking at your tissue, because you could have prolapse or you could have a lack of estrogen. For men, if you haven't had your prostate examined, then that's going to be an important aspect, because if you have an enlarged prostate, it can cause frequency and urgency. One of the things you're going to be asked, at least if you come to see me, one of the things you're going to be asked to do is something called a bladder record. And I'm pretty sure I have a slide in a little bit that's going to talk a little bit more about that. Depending on what's going on, especially if you're a gentleman with a prostate or a potential prostate issue, they're going to ask you to have blood work done. But that's the simple thing. Those things are usually going to happen. We may also do a bladder scan to make sure that you're emptying your bladder. But then the other diagnostic test that may be done wouldn't be done on that first visit, and there would be a conversation with you explaining why those would need to be done. But often, no additional testing needs to be done. So what is this overactive bladder? So it is frequency and urgency to urinate, and with or without leakage. So I have individuals that come in that just feel like they have to go to the bathroom all the time. They have a sense of urgency, but they never ever have any leakage. Individuals that might be urinating 15 to 20 times a day or getting up 4 or 5 times at night. Again, no pain, just a sense of urgency and never any leakage. But then there's the group of individuals that have the frequency and urgency, but can't make it to the bathroom. And they may have leakage on the way to the bathroom, not every time, or maybe every time. But that is called overactive bladder wet. And the other one where you don't have any leakage is called overactive bladder dry. The symptoms of overactive bladder are that sensation of having to urinate now. You gotta go. I'm sure all of you have seen those commercials on TV that gotta go, gotta go, gotta go. And so that idea is all of a sudden you may get this very overpowering need to pass your urine. The other thing I always say is that you have a strong urge and you feel like you're going to go to the bathroom and you're going to go gallons and you go a little bit. It's actually disappointing based on that sense that you had on how strong it was to go. And then you only go this little bit. You may feel like you have spasms in where your bladder is, and that's right above your pubic bone. And so in that area, you may feel a spasm. You may get a sudden urge and it comes on at the same time that you have leakage of urine. And for individuals, it's important to know it's when you're going to the bathroom more than 7 times a day that is considered overactive bladder. When we talk about overactive bladder, it's really important for you to understand the different causes of overactive bladder. So it's usually a change in the nerves or muscles that control the bladder. And these things can be caused by diabetes, because remember, individuals think of neuropathies with diabetics in regards to their feet or their hands, and they have to be careful when they're walking and not bumping their legs, but the diabetes can affect the nerves in the bladder. There can be neurological issues like MS or stroke or Parkinson's that can affect the bladder. You can have had surgery that can affect the muscles, the pelvic floor, the bladder, that can affect it. Radiation therapy can affect how your bladder functions. Amazingly, the types of foods you eat and the fluids that you drink can have a big factor on your bladder. If women have prolapse of the vaginal walls or of the uterus, again, that lack of estrogen or an enlarged prostate, some of the medications you take. So I always tell people, if you're taking a water pill for your high blood pressure or for fluid swelling, that medication, its purpose is to make you go to the bathroom more often. You're not going to be able to put off the urge. You're going to need to go. So those changes in estrogen, I have it twice. I guess I really wanted to emphasize how much estrogen or lack of estrogen can make a difference. And your weight. One of the things that we do know is that weight, that extra pressure abdominally, can push on the bladder and cause more urgency and frequency. However, I always like to clarify that I have both women that are overweight and underweight that have overactive bladder. So just because if you are overweight doesn't mean you shouldn't be evaluated, because there are still things we can do. There is a myth every person who comes in to see me, one of the statements is, I don't drink as much as I should because I'm afraid I'm going to have to go to the bathroom. However, the less you drink, it is not true, the less you will need to urinate. And the reason that is because when you don't drink very much, that urine that's going into your bladder becomes stronger or more concentrated. And it almost like irritates the lining of the bladder, and that can cause more urgency to pass your urine. It is crazy. Women think that I'm crazy when I tell them I want you to drink more water, and some of that urgency will get better, and many times it does. So let's go on to talk a little bit more about the things you need to know. So it's really important to understand how your bladder works, because if you don't understand that, you can't understand why we're recommending certain treatments. So one of the things you want to understand is that it's your brain over your bladder, not your bladder over your brain. And I know many people feel that their bladder is controlling their life. So let's talk about the parts of the system that controls your bladder or gives you better control with your bladder. So your bladder is actually a muscle, and I'm going to show you a picture of that in just a second, but it's actually where the urine is stored. And my description is this bladder is a storage tank that's low pressure, and that 95% of the day, it should just be hanging out, chilling, holding urine. The only time that bladder muscle should do anything than be relaxed is when we pass our urine, because actually when we pass our urine, our bladder contracts. The urethra is the tube that goes from the bladder to the outside. And in that urethra, there are sphincters or doors that help keep that urethra closed. But it really is just that passageway. The bowels can play a role in bladder overactivity because if you're constipated or have a really difficult time moving your bowels, the constipation can press on the bowels, but if you're straining a lot, it can affect your pelvic muscles. And your pelvic muscles are the supporting structures for both the urethra, the bladder, and the sphincters in the anus. So let me show you where these parts are in your body. So normally if you were in my office, I don't know if you can see me, your kidneys are in the back, and that's where the urine is produced, and it goes down, and I don't have a pointer, and I don't think you can see me if I point on it, but the tubes that go from the kidneys down are called the ureters, and then your bladder is right there, and that's where it stores all the urine. And the passageway is here from the bottom of the bladder to outside is the urethra. In women, it's a very short. In men, it's much longer. That's why women are much more at risk for incontinence than men. However, men after prostate surgeries can be more at risk. So here's a nice cross section. If I was standing sideways and you were looking inside, I don't know if you can see my mouse, but here's the bladder right here. Here's your pubic bone. Here's this urethra right here, the uterus, the vagina, and the bowel. And your pelvic muscle goes from back at your tailbone down underneath to your pubic bone. And when we talk about pelvic muscle exercises in a little bit, that's that area that we're working. And when we talk about men, again, here's the bladder. Here you can see their urethra is much longer. Here's the pubic bone. And again, your pelvic muscle goes here underneath, up, and to your tailbone. And that is the muscle when we talk about getting a little bit better control of our pelvic floor that we often use. So what's supposed to happen when you get an urge to urinate? So I don't think I have a picture here, so I'm just going to go back and talk. So what happens is when we go to the bathroom, I told you that your bladder muscle squeezes or contracts, at which point all the urine hopefully has emptied, and it is normal to leave up to about 3 ounces behind. That can be absolutely normal. But then at that point, after you go to the bathroom, you start to drink fluid or you eat, and your bladder muscle actually begins to expand like this. And then what happens is you can get a slight urge. And how that happens is there's little sensory nerves in the bladder, and they send that signal up through the sacral roots or the sacral nerves, and it goes up through your spinal cord to your brain. And your brain goes, oh my gosh, I have to go to the bathroom. However, Kathie's talking to us on this Zoom meeting, so I can't go. And your brain sends a signal down through the spine, through those peripheral nerves to the bladder, and it says, bladder, relax, you can't go right now. And so the bladder relaxes, and that urge should go away. Now, we go on with the conversation, and maybe at the end of the meeting, you feel like you have to go to the bathroom, but your dog needs to go out, or somebody calls you on the phone and you pick up the phone. At that point, that same process should happen where your brain controls your bladder and it settles down the urge to go to the bathroom, and your pelvic floor and your sphincters tighten, and that urge goes away. So then a little while later, you'll get what I call is that 911, oh my gosh, it doesn't matter what you're doing, you have to go to the bathroom now. But again, your brain should control your bladder until you get to the bathroom, at which point, once you're sitting on the toilet, your brain goes, okay, you're at the right spot. And at that point, passing your urine is really just a reflex. The nerves tell the pelvic floor to relax, tell the sphincters in the urethra to relax, and that bladder muscle squeezes and we pass our urine. So that's how, there's a lot behind going in and passing your urine. So again, it's your brain over bladder, not bladder over brain. And we want to remember that, because as we go along and we talk about the different treatment options, it's really important to keep that in mind. So let's talk about what's normal, because I have people come in every day that think that they're normal and they're not. So it is normal to drink 48 to 64 ounces as long as you don't have a medical restriction. So keep this in mind. If you're drinking a gallon, which is about 128 ounces, if you're drinking that, you're going to have to go to the bathroom more often. When you're less than 55 years old, it's normal to urinate 6 or 7 times a day. And over the age of 55, it's still normal to urinate about 6 or 7 times at night, but it might be normal to get up once or twice at nighttime. Your bladder should hold about 1.5 to 2 glasses of fluid. And if you think about that in ounces, it's about 10 to 20 ounces. And you should have that control, and this is what is normal. So this is what I'm always trying to help individuals achieve. And remember that it's not normal to leak at any age. And not that we're not talking about stress incontinence tonight, but I have so many individuals who have leakage with coughing, sneezing, laughing, maybe after childbirth or when they get older. And again, they think that it's normal, but it is not normal. It's very common, but not normal. So there are age-related changes, but that doesn't mean that you have to live with overactive bladder. So what can happen is your bladder can hold less volume. Instead of maybe holding 10 ounces, maybe 8 ounces is going to be more normal. You can have that bladder, instead of being relaxed and being well controlled by the brain, it can squeeze without warning. And that's when you get that sudden urge and the urine just starts to leak out. Those anatomical changes that I talked about, whether it be an enlarged prostate or prolapse in women, that can actually be an issue. When we talk about estrogen, that lack of estrogen happens after menopause, and so that can be an issue. As we get older, what's crazy is we hold less, but sometimes our bladder doesn't empty as well, so we leave a little bit more urine behind. And again, I have anatomic changes twice. I apologize. So we'll talk about that prolapse again. And there's also a delayed warning to urinate. I don't know how many of you out there are either teachers or nurses or individuals who might have worked on construction where a bathroom wasn't accessible. So you were able to hold your urine until you got that 911 urge. And what happens is, over time, those initial warning urges, you may not get. So when you have to go, you really have to go. There's not that warning and that normal urge. It's you gotta go. And I can remember 35 years ago when I was a new nursing student, people would ring the bell in the hospital and you'd go and you'd say, I'll be right there. And by the time you got into the bathroom, they'd have an accident. And I remember learning about this and being much more educated to say, oh my gosh, we have to address those call bells right away, because a lot of times when individuals, when they're older, call to go to the bathroom, they really need to go now. You know, when you talk about overactive bladder, it affects so many aspects of our life. It affects the quality of life. So how many things you can do in it, what you're doing and where you do them. You might not want to go out because you're afraid that you're not going to be able to make it to the bathroom. I actually had a patient today that says she doesn't want to go out of her home too often because she's afraid that she's not going to be able to find that bathroom. They have showed in studies that individuals that have overactive bladder are less active. They're afraid to do activities. And then if you always feel like you have to go to the bathroom, or if you feel that way and you have leakage, it affects our intimacy. And many people come in and say, I didn't realize how much it was affecting my life until after I got it fixed. And that happens so often. It's so common. So let's talk about getting control. What can we do to help us get better control of our bladder? And so what are some effective treatments for overactive bladder? And you want to remember that nothing is impossible. The word itself says, I'm possible. And all of you, if you're experiencing these issues or you know someone who does, it is very possible to make a huge change in your life. First, remember, I feel like I'm beating a dead horse to some extent here, but we have to treat those underlying issues first, such as diabetes or prolapse, or even sexually transmitted infections can cause frequency and urgency. If you have an enlarged prostate, we have to address that, the medications that you're on, and then that lack of estrogen. We want to make sure those things are under control, because if they're not, or if that is an issue, or if we're not aware of those issues, then what happens is we may try other things and they won't be as effective as they could. So one of the things that I want to just touch base on is topical estrogen for women. How it works is, one of the changes with menopause is that lack of estrogen, and women can get vaginal dryness, they can get pain with intercourse, and the tissue in the urethra and the tissue in the vagina are embryonically similar, and so they get those same changes. So when you get that vaginal dryness, you can also get that urethral dryness, which causes increase in frequency and urgency. It can also cause more urinary tract infections and pain with sex. There's a whole ton of things it can do, but we're focusing tonight on that frequency and urgency. That lack of estrogen after menopause is called genitourinary syndrome of menopause. And we can actually reduce or cure it in 2 to 4 weeks of estrogen therapy. And it's topical estrogen, not oral estrogen. When we talk about delivery methods for that, we can use a vaginal cream. We can use, and I have a typo here, it's estradiol cream, not estradiol. There's something called an E-string where it just folds up and it goes into the vagina and it stays in there for 3 months. There's a tablet that can go in, and there's even a little suppository. So there's all different methods to actually to use that estrogen, and it works wonderfully. There are also non-estrogen based therapies, such as something called Intrarosa, and it's a nightly vaginal suppository that goes in. So there are no risks in regards to that estrogen.
Superstars from the city of brotherly love: Paul and Oates, Teddy Pendergrass, Billy Paul, Patty.
If somebody, yes, if you could mute your thing, thank you. So one of the questions, actually, this is the question I get every day from women when I talk to them about vaginal estrogen and is it safe? And what they found when they did a review in 2006 is that there was no increased risk of clots or using low dose vaginal estrogen. And what they also found was that there was not an increase in those levels of estrogen within the bloodstream. And you were still within that normal postmenopausal level. So therefore, thickening of the uterine lining is not really an issue. However, if you're having any vaginal bleeding prior to starting, you wouldn't want to start this. It's one of those things that you can talk to your gynecologist about or your primary care physician if you're postmenopausal and having some of these symptoms. I want to talk about behavioral therapy because I find that a lot of people don't understand it. Physicians sometimes don't understand it or how it works. So we're going to talk about it now. It's really the first line therapy when we talk about overactive bladder. And so the first thing that is really important, and I talked about this briefly and said I was going to talk about it a little bit later, is a bladder record. And the bladder record is really important to help you and I determine what's going on with your bladder. There are very fancy tests that we can do to see how your bladder is working, but I'm going to tell you a bladder record gives us so much information. But I want to tell you, it's kind of a pain. It's like Weight Watchers for your bladder. And you do this for 3 days. And what happens is you keep track of what you drink and how much, what you normally do. You're not getting graded on it. You're not going to be reprimanded if you're drinking too much coffee or tea. But the idea is to get an idea of what your normal fluid intake is like. Then you're going to keep track of when you go to the bathroom and how much you go. And why is it important to know how much you go when you pass your urine? Because we want to see what is your normal bladder function. Remember, I told you the bladder should be able to hold about 10 to 20 ounces. So if you come in to see me and you have overactive bladder, but every time you pass your urine, it's only about 3 ounces, then we know your bladder's not holding very much. Or maybe you'll come in, and I've had this happen, where I've said to patients that, hey, your bladder's working fine, you're just drinking way too much. They might have been drinking that 124 ounces of water and 2 cups of coffee and an alcoholic drink. And then when they look at their bladder record, all of their bladder volumes are normal. So we can still work at training their bladder to give them a little bit better control if they're having any leakage. But the idea is their volume and their bladder muscle is working just fine. So the goal of that bladder record is to help you and I understand how your bladder is working. The next thing we need to understand is that there are dietary things that can affect our bladder. So there are irritants, such as, and listen, I'm a tea girl. I love my tea, but I know I have to watch and limit how much tea I drink. But things that can irritate the bladder lining are coffee, teas, soda, alcohol. So diet sodas are worse than regular sodas. However, sodas across the board will irritate the bladder, causing more urgency and frequency. The same thing with acidic foods and fluids. Spicy foods, nicotine. So if you're a smoker, that increases your risk because it can irritate your bladder. And realize that if you're a smoker, that nicotine increases your risk for bladder cancer. Elevated blood sugar, because if you're spilling sugar in your urine, that causes more frequency and urgency. But so those are things we want to limit. So carbonation is another item that can irritate the bladder. Does this mean you can never have these again? Absolutely not. But you want to try to identify. Most people that come in to see me say, I want to have better control. So to have control means to understand what's happening. So eliminating these things, you may see a 50% improvement in your bladder. Maybe you'll see no change, but for many people, they do see a difference. And many people know that when they come in, that they can tell me right off the bat that, oh my gosh, if I drink coffee or tea, I have to go to the bathroom more often. And then I explain to them why. The other thing we want to do is eliminate any constipation, okay? Because constipation, remember we talked about that, is going to press on your bladder. But the other thing that it's going to do is it's going to cause strain, if you're straining to move your bowels, more pressure on your pelvic muscle. So to help eliminate constipation, that's not listed on here, is a Squatty Potty. It's helping your posture during evacuation. Those of you that are older that remember what phone books were, I used to tell patients to keep your old phone books and put your feet on the phone book. So I really should have invented the Squatty Potty, because then I could have been a millionaire. But the Squatty Potty is just a little stool to put your feet on. So it opens up what's called the anorectal angle. It makes it so much easier to move your bowels. You want to increase your fiber. You want to make sure that you're getting enough fluid, that 48 to 64 ounces, and increasing physical activity. The other thing is when you're sitting down to move your bowels, it's very important that you don't strain. When you strain, the majority of individuals, their pelvic muscle tightens, and it actually makes it harder to move your bowels. So doing nice deep breathing in and out of your mouth as you're trying to move your bowels can actually help reduce the amount of straining that you have. Oh, and there's my Squatty Potty. That's that little stool that's right here, and it helps the angle. The next thing, and what I think is the most important thing, are pelvic muscle exercises, AKA Kegels or Kegels, people call them. And they've really gotten a bad rap because so many people that come in to see me say, you know, Kath, I've done those exercises and they just don't work. Well, the problem is that most people don't do them right. They do them incorrectly. They try to stop and start their stream, or they're pushing down, and it's very hard. And so the idea is we want to make sure when you come in for that visit that how do you do them and why do them. So we're going to talk a little bit more about that. So let me back up a little bit. So first I'm going to talk about how to do them. So all of you, if you're sitting watching this, the goal is that it is the muscle that goes, remember I showed you that picture in the beginning, it goes from your pubic bone to your tailbone. So that's a group of muscles called your pelvic muscles. And that is that when we talk about just pelvic muscle exercises alone, that's what we're trying to work and strengthen. So you can either imagine holding back gas, tightening vaginally, or drawing in vaginally as if you were holding in a tampon, or imagine your vagina was sucking on a lemon and drawing in, or you can imagine stopping your stream of urine. For men, a lot of times, if you're doing this exercise right, the penis will actually lift up a little bit, all right? Now, here's the hard part when you do these exercises. No belly, no butt, no thighs, and you have to breathe while you squeeze. So the difficult part is many people think, like I said, that they're doing them right, but when they come in for an exam, they either have a very minimal contraction or they're bearing down. But you can try to do these at home. Now, many people have heard, oh, Kathie, I should stop and start my stream. And I say no, because remember, I told you in the beginning that when you're passing your urine, your bladder muscle's squeezing. So then trying to stop that stream of urine is a lot harder. To tighten that muscle is a lot harder. And the other problem is remember, we talked that as we get older, it's harder to empty our bladder. So if you stop that stream, it may not start back up again. So if all of you are sitting, if you can sit and put your feet on the ground, and what I want you to do is focus on those areas, holding back gas, tightening, if you have a vagina, tightening vaginally, or stopping your stream of urine. And what I want you to do with keeping all the other muscles in your body relaxed, I want you to try to draw in or tighten. So if you put your hand on your belly, you shouldn't feel your belly move, and it's just tightening that muscle. And then you're just going to let it relax. And now I want you to try to tighten it again, and then just let it relax. That's what's called a quick flipper. We're just trying to find the muscle. And a Kegel really is the definition of where you're going to squeeze and try to hold that muscle tight. And I tell individuals to start at about 3 to 5 seconds of holding it tight, trying to maintain it. But what happens when you're breathing, that muscle wants to relax. So a lot of times when you're breathing out, you need to re-tighten that muscle. So that's why when you come in to see me if you come in to see a provider like myself, they're going to do an exam. And during that exam, they're going to teach you how to do these exercises. But that's a little bit of a starter that you can try to find that muscle at home. So why are you going to do these exercises? Well, a couple different reasons. One is they help support the urethra. They actually help close the sphincters. They actually help with the anal sphincter too, of tightening that. But doing pelvic muscle exercises can reflexively, meaning it's just a reflex, help that bladder muscle relax. Remember, we want that bladder relaxed 95% of the time. So there are assistive devices to help people identify the muscle or work the muscle. For females, there's something called vaginal weights. And these are something you can get on Amazon. And they actually go in the vagina and they actually help you find your muscle and tighten that muscle. A lot of women really like to use these because it's just another way, it's a biofeedback mechanism that they're doing the exercise right. And I always tell women, you know, we're all very busy, we're active doing things. So one of the great times to use these vaginal weights are in the shower. And I've had so many women say, you know what, Kath, if I stand there holding the weight in place, I'm fine. But as soon as I raise my hands to wash my hair, the weight falls out. And that can happen. But the idea is we're going to gradually strengthen the muscle. So you start with the lightest weight, you hold it for 5 minutes. Once you can do 5 minutes, you go to 10 minutes. Once you can do 10 minutes, you go to 15 minutes. Again, we want to make sure that you don't have any prolapse or anything like that, because that would hold the weight in. So you wouldn't really be getting the exercise as well. For men, these weights really are not something we're going to talk about using. There's something called stimulation therapy and biofeedback. And you might have heard of biofeedback. And the idea of that is it's going to give you information on what your muscle's doing. So that's the biofeedback option. The stimulation therapy, so many people come in to see me and they either have a very weak muscle or they can't find their muscle. They're not really able to breathe and contract their muscle. So stimulation therapy is a method. We use a sensor either in the rectum or in the vagina, and it actually works the muscle for you. No, it's not painful. No, it doesn't shock you. But the idea is it helps you find the muscle. So it's putting that relationship of the pelvic muscle and the brain so that you're able to do the exercises. The biofeedback, what we use in our office is a computer that actually you can actually see it. And I have a cute little slide here that what happens is the sensor goes in the vagina and you can actually see what's happening with your muscle on a computer screen. So you can see if you're able to maintain that squeeze for 5 seconds or 10 seconds. Can you maintain the squeeze just for a second? How strong is your muscle? We can set goals to be able to make it so that you can work on maintaining that contraction and breathing. So it's not painful. I always try to explain it. It's weird, but cool because it is very helpful. They've shown in studies, women or men that do biofeedback to assist with pelvic muscle exercises have a much better outcome. Here's the problem. You have to do them every day, all right? So you have to do at least 40 squeezes, not 40 sets, but 40 squeezes. So if you're doing sets of 5, you have to do them about 8 times a day. If you're doing sets of 10, you have to do only 4 sets of them a day. So my favorite saying, and if any of you have ever seen me, you know I'm not lying, my favorite saying is every time you pee, think of me and do 5 exercises. Soon I'm going to start handing out pictures of myself so you can put it in your bathroom to remember to do the exercises. Because the first thing that's hard about these is you have to find the muscle and you have to be doing the right muscle. You don't want to be wasting your time. But the second thing is doing them and incorporating them to everyday life. And you really need to do them for the rest of your life. It's like any other exercise that you do. Once you stop doing it over time, that muscle will go back to the way it was before. Now, the other thing I want to stress, that constipation issue and straining, even individuals that have more of diarrhea, if you're having an IBS where you go from constipation to diarrhea, those episodes of diarrhea, the episodes of constipation are going to work the opposite. So you might be going 2 steps forward, 1 step back, but you can keep moving forward. Remember, it's very possible to make significant change. So now that you've learned the exercise, and you say, but Kathie, that's not going to help me get better control of my bladder, but it's a stepping stone, because the next thing we're going to add in is something called bladder retraining. So I've been doing this actually now for probably 34 years. And when I went to get trained, my son, who is now a dad, and I think he's 34, he was toilet training when I was doing when I was working this. And one of the things is, remember I told you your brain controls your bladder. But our instinct is when we get that strong urge to go to the bathroom, we're going to run in to go to the bathroom and urinate. Well, he used to run into the bathroom and be peeing on the way into the bathroom. So I figured, why not use him as my guinea pig and try this out on him? So I would say, oh my gosh, if he knew I was talking about him, he'd be laughing. But so I would say to him, Quinn, you need to stop and let's take some deep breaths and focus on your breathing. And then we'll go into the bathroom slowly. And he found that it worked. However, one time when he waited too long outside, he came to me and he says, Mom, I did that breathing and everything, and I still couldn't quite make it. But again, with kids, if you push your bladder too far, if you wait too long where your bladder's overfull, it doesn't matter what you do, it's going to be harder to control it. It's like a dam that's overflowing. So let's talk about this bladder retraining. What we're going to do is we're going to retrain our brain to get into control. So imagine you went to the bathroom a half an hour ago and you know you don't really have to go again, but you have that urge. So what we're going to do is we're going to use a combination of exercises, breathing, and distraction to get that urge under control. So what you have to do is you have to stop what you're doing. You're going to take 5 slow deep breaths in your nose and out your mouth. So you're breathing in and breathing out, focusing on your breathing. And then what you're going to do is you're going to do 10 quick contractions of your pelvic muscle. And at that point, you're going to go in and go to the bathroom. The idea at first is you're just going to get the urge under control so that you know that you can settle it down. And once you can do that, then you extend the time to about 15 minutes, and then you can extend it longer. It's also really important not to urinate and do that preventative toileting, meaning, oh, there's a bathroom here, let me go use it. You know, with COVID and everybody being home more often, one of the issues is we start getting into some bad bladder habits. You get that slight urge and you go to the bathroom. So that's how we do that bladder retraining. There are specialized physical therapists that can actually help. If you come to see me, or maybe you can see them and myself at the same time, I refer out often for help in regards to finding your pelvic muscles, but also to work with pelvic stability, to look at other muscles that are affecting your pelvic floor, such as your hip and your back, because that can also be affecting how well your pelvic muscle is working. So that behavioral therapy is that first line therapy. The second line therapy is medication. Now you could come in to see me and say, Kath, I've tried those things, I just want to start medication. That's absolutely fine. Remember, when I see patients, the goal is that you're empowered. I'm going to educate you on all of these things, and then we're going to make a decision together on what's going to work best for you. But medication is what's considered a second line therapy, and they really do work. But the problem is that most people stop taking these medications within 6 months, either because of cost or a lack of effectiveness or side effects, or they just didn't know they were supposed to keep taking the medication, or they don't want to be on medication forever. So one of the things that I think works the best is a combination, if you want to take medication, is a combination of the behavioral therapy with the medication, so you get the most bang for your buck and you're going to retrain your bladder. You need to understand that this medication does not work after 1 or 2 doses. It can take 4 to 6 weeks to make a significant difference. So you have to keep that in mind. Once you start this, we need to give it a little bit of time. There's medications called anticholinergic, and their purpose is to relax the bladder muscle by blocking the action of a chemical messenger called acetylcholine. And what it does is it allows that bladder muscle to not be as spastic and relaxing. And the goal is to reduce the urge and the overactivity of that bladder muscle itself. You might have heard of some of these names: oxybutynin, toltolerdine, darafenacin, sulfenicin, trospium, fistoterdine, which I can never say. I always want to warn people, oxybutynin is usually the first line therapy that insurance companies want to cover. As we get older, they have shown in studies that it can cause cognitive or mental changes. So I always like to warn people, it is not a medication I usually prescribe anymore after those studies were shown, one of those other medications. However, oxybutynin is usually the cheapest medication. Potential side effects of these medications can be dry mouth, constipation, blurry vision. You cannot take these medications if you have acute narrow angle glaucoma. You can get a rapid heartbeat. For individuals, they can have a difficult time emptying your bladder. And I've already talked about these cognitive side effects. There's newer medications called beta-3 adrenergic agonists. And what they do is they cause relaxation of the bladder muscle, and they increase the amount your bladder can hold. They work at the chemical level of the nerves. And these medications can work really well. There are now 2 of them. Myrbetriq has been out longer. Gemtesa is a newer medication that's out. They're both the same category. And the biggest difference is Myrbetriq, one of the side effects, it can increase your blood pressure. Gemtesa does not do that. My daughter was fixing my slides and she wrote this TI, so I have no idea what we were talking about here. I have to apologize. Myrbetriq does say, again, it can elevate blood pressure. And I've only seen that happen in maybe a handful of individuals, but when you go on that medication, we like to check that. The most common side effects usually when we talk about these 2 medications are allergy-like symptoms, headache, back pain, but the real ones are these allergy-like symptoms that they seem to notice. You can still get some constipation, but that's not as common. So what happens if you do your bladder retraining and you try medication and you're not seeing a difference? There are 3rd-line therapies that are very effective. However, you do have to, insurance companies require that you have tried 2 medications and failed. And what that means, doesn't mean you have to be on a medication for 6 weeks if you're getting a side effect. What it means, you have to try it. And if you get side effects from it and they're intolerable, you can stop that medication and it counts, excuse me. Or if you take a medication and you don't get improvement, or maybe you get a little improvement, but it's not as much as we would have hoped for. So the first one I want to talk about is Botox. And Botox, yes, it's the same Botox that they use for migraine headaches, that plastic surgeons use for, as I say, my number 11. So it's the same thing. It's injected into the bladder. And you can see here, they just use a little cystoscopy and then they inject this medicine into the bladder wall. And it blocks the nerve signals. Therefore, what happens is it calms the bladder down. So you're not having that sudden urgency. So it causes that bladder muscle to relax and it gives you time to get to the bathroom. In about 5% of individuals, they can have a difficult time passing their urine. And so sometimes some physicians like to have individuals know how to catheterize themselves or know that that is something that may need to happen. It's temporary, it goes away, usually within 2 months, but you need to be aware of it. The other issue with Botox is that it only lasts about 6 months. So you may have to get it done, well, you do usually have to get it done anywhere between every 6 to 12 months. It is very effective and a lot of people have this done. The neuromodulation is something that reprograms the nerve communication between the bladder and the brain. And if you remember when I talked earlier that the bladder, the nerves that go from the sacral nerve root are outside the spinal cord, but right at the bottom, they're called peripheral nerves that go up to the spinal cord to the brain. These peripheral nerves is where neuromodulation works, okay? And it helps that communication. And the idea is there's better coordination between the brain, the spinal cord, and those peripheral nerves. And so it normalizes that communication, okay? There's 2 ways to do this. And one is called percutaneous tibial nerve stimulation. And what we do is we just put a little acupuncture needle at the tibial nerve, and it sends these electrical impulses from that tibial nerve to the sacral nerve, which then, and that's that group of nerves at the base of the spine, and they're responsible for that bladder function. So it helps that coordination again between the brain and the bladder. This is weekly treatment sessions for about 12 weeks, and it's a 30-minute session, and then it's done monthly. So it works, it's non-invasive. There are really no side effects to this except for time. It's very time intensive for patients, and that you need to do those 12 sessions consecutively, okay? And this is what it looks like. A little needle like this goes in and it's connected here. And the sensation you feel is either your toes will curl or you'll feel a sensation in your foot. It doesn't hurt. The needle going in doesn't hurt, and it doesn't have to go in real far, and it is amazing. I have quite a few patients that are doing it right now, but over the past time that I've worked doing this, I've seen a lot of patients doing PTNS. I have some of these patients that do this PTNS and then move on to what's called Interstim. And this is more of a device that same process, not the same process, the same it functions the same way, but it's more constant. Instead of coming in and getting that stimulation therapy every week, you're getting constant stimulation to the nerve. What's even more interesting or exciting is that there is a test to do. Okay, it's called it's a percutaneous nerve evaluation. And what they do is you go and you have this wire or this lead placed to those sacral nerves, and we test to see if it works. So it's either going to work or it's not. So if it works, the idea is that you get a 50% improvement in your frequency, urgency, or leakage. And what's even amazing with this, because it works at the nerve level, it also works for individuals who can't empty their bladder, and it also works for fecal incontinence. After you do the test, and if it works, they actually implant, they put it internally, a little battery and the leads. And the battery now is rechargeable. If you want, you can either get a rechargeable battery or a battery that is not rechargeable, and you have to get it changed every 5 to 7 years. It can be removed. It's not something that's permanent. You don't need to do anything to pass your urine. You can still pass your urine normally. And the idea is this is done and you don't have to think about your bladder anymore. Previously, until about a year and a half ago, it was not MRI compatible, but now it is MRI compatible. So that battery that's rechargeable is good for 15 years. And they're finding that it may last even longer. But the control is all through the nerves. And remember, the medications work more on the muscle itself, more so than the nerves. These are all my pleasant pictures. The goal, hopefully tonight, I wanted to leave some time for questions, but that you all understand that you have freedom to not just live with this problem, that there are things we can do to make it better. Again, from simple things such as behavioral changes to things that you would think are amazing, I think, like Interstim and Botox, that we didn't have 15 years ago. And actually 30 years ago when I started doing this, or 35 years ago when I started doing this, there was only one medication, and it was oxybutynin, and it wasn't an extended release. And we had to break these little pills up into a quarter of the size, and they didn't work very well, and they got severe dry mouth. And so back then, all we had was really behavioral therapy. Now we have so much more to offer our individuals. I know I sped up at the end a little bit because I saw that we were getting close to the end of time. So what I want to do now is answer any questions that you have. I'll look in the chat box first. I don't know if there's any. Oh, you know what? Let me talk about this. Somebody brought up, is this appropriate session for people with interstitial cystitis? And I didn't get a chance to talk about that, but let me briefly talk about interstitial cystitis. Interstitial cystitis individuals have frequency, urgency, usually with pain with bladder filling or pain with bladder emptying. It almost feels like you have a urinary tract infection, but your cultures are negative, and maybe you've tried to use an overactive bladder medication and it hasn't been effective, or maybe you've even done an Interstim and it is not working as well as you'd like, or you still have pain. So interstitial cystitis is actually a treatment that we work with in my office. We do a variety of things such as bladder rescues and medication and dietary changes. But a lot of the behavioral things that we've talked about can make a difference to some extent with interstitial cystitis, especially dietary changes. Maggie, I don't know if you can easily see if there's any questions.
I don't see any questions in the chat box, but if anybody has questions, please ask Kathie or put them in the chat box. And also just a reminder to please complete the survey when we're all finished, which is in the chat box.
Okay, my name is Don, if you can hear me.
Hi, Don. I
was interested, I have taken both oxybutynin and Myrbetriq, and another one really that doesn't work.
Okay.
My question is, does insurance usually cover Botox, or?
Yes, absolutely.
And does the doctor need to prescribe it?
So what happens is, do you see a urologist?
Yes.
So your urologist, once you've failed 2 medications, you are a candidate unless there's something else going on. And that's something to have that conversation with your urologist. But yes, it's something if they do it. Not all urologists do it, But it is definitely, if you've tried to and it hasn't worked and there's nothing else going on that we need to be concerned about, like have you had radiation therapy?
No.
So,
My doctor told me this is it. There's nothing else,
oh,
after.
no.
And do you have to do it every 6 months, or you said?
So the Botox, a lot of times the company recommends to be reevaluated every 4 months, but patients can go. What I've seen is when it starts wearing off, your symptoms start coming back. And
Right.
so the idea would be some providers do it based on your symptoms. And when they're coming back, other people just like you to come back every 6 months or 9 months based on how you're doing. But yeah, it has to be redone. That's where the Interstim doesn't have to. Once it's placed, it's done, and you don't have to, until you need a new battery, you don't have to do anything.
Okay, thank you.
Oh, you're welcome.
Oh, excuse me.
Hello, yes, Kathleen?
Oh, yeah. But first of all, my camera is turned off.
That's okay. You can still ask.
Okay. I have pre-diabetes,
Okay.
high cholesterol, and I get seizures during my monthly hormonal menstrual cycle. You talked about estrogen down there, and I heard that one of my doctors said that my estrogen is not processing properly. It's not cycling properly. So could I be one of the 40% of women who have urinary problems or need some help with my bladder or with some kind of hormone down there? Could that affect everything with
Sure.
menstrual cycle and everything?
So it depends on your age, but even women that are younger, that are on birth control pills, sometimes need a little estrogen topically to that area. So it all depends. For you, you sound like especially if you're having seizures, part of it'd be a little bit more complicated. So for you, I would definitely say it's worth coming in and having an evaluation, especially if you're having bladder symptoms, to come in and try to come up with a plan that would work for you.
Okay, because I'm on progesterone and I'm wondering if what is that estrogen in the vagina thing about?
So it's just, again, to actually help with the lining of both the vagina, but in the urethra and the bottom of the bladder. So that's the purpose of it, to reduce some of the urgency and frequency if on exam it's identified that that's something that's going on. So the purpose is to come in and have that exam so we can determine if that's something we feel would help you.
Thank you. And what's that battery thing that you
No, the Interstim. So that's for the frequency and urgency. So you have to have tried 2 medications and failed. But then think of it as almost, how I like to describe it is, how a pacemaker, many people know how a pacemaker works. It kind of re-regulates the process of the heart, where what Interstim does is it normalizes that communication between the bladder and the brain. And so that instead of your bladder being overactive, it now settles it down so that you have better control, less urgency, less frequency, and less leakage if you're having leakage also.
oh
Okay.
I don't wet the bed, but do you have patients who wet the bed? Or?
Oh, absolutely. I have people, remember we talked in the beginning that you can have overactive bladder symptoms with or without leakage. So there are people that do have leakage at night and individuals that don't have leakage at night, but both can be helped.
Thank you.
Oh, you're welcome.
Hey, Kathie, it's Renee.
Hi, Renee.
Actually, hi. I have 2 questions for you. One question is about me. I am your patient, and I recently started with the I don't know how to pronounce it.
Rebecca.
Yes. And I seem to get an improvement in 2 days, but then it didn't last. So I'm still taking it. But I seem to be getting swollen ankles. I seem to be getting my ankles swelling up a little bit. And I don't know if it's from that or. So
it's possible. It also could be because the heat is so bad right now. The summer heat and the humidity can do it.
Okay.
So what I would say, Renee, if you're having that issue, we can always have you pop over and we can check your blood pressure and just check you and make sure everything's okay. That's not a problem. So just give the office a call and we can have you come in.
Okay.
And
So
what was
my
the second question?
My second question is actually about my daughter. You mentioned quickly neurological problems, and I have a daughter with MS, and she
Oh,
is yeah. So I
Yeah.
was wondering, do these things help that also?
sometimes, yes. So MS, remember we talked at the beginning that there can be neurological issues that can
Yeah.
cause that bladder issue. So with MS, every person is different and how their MS affects their bladder. So some people can't empty their bladder, some people go too often. So we can certainly work with individuals with MS. I have quite a few patients with MS that we've been able to make a significant difference. The first thing I would tell your daughter to do is to stop drinking any caffeine. For individuals with MS, we find that it's actually even more irritating to the bladder than others.
Okay.
What?
Caffeine. Does soda fit in that category also?
Yes, it does.
Okay. I wondered.
Unless, well, let me clarify, unless it's Sprite or ginger ale. But any of the other sodas, and I think even orange has a little bit of caffeine in, I think, and like you want to avoid the Mountain Dew. We used to tell people that light color sodas were better, but then I would find people who would drink Mountain Dew, and that's one of the worst. So I would avoid sodas for sure.
Okay.
Okay.
Thank you. Yes.
Oh, you're welcome.
Are there any other questions?
So would you please explain this whole thing about the estrogen in the vagina again? Are there different vaginal things, or is it one and the
There's
same?
different-
Or how
There are different methods of delivery for vaginal estrogen. Yes, there's a cream, there's a little suppository, there's a little tablet that goes in, there's a ring. So there's different methods that we can use, and they're all equal. Well, not all of them. I'm not a big fan of the tablet, because if you have a lack of estrogen, then the problem with that is that it often won't.
Must have a glass of ice and bottled water.
Pardon me?
Oh, the waitress came.
Oh.
Okay.
So there are different methods of delivery that you can use when we talk about vaginal estrogen.
And where's your office located?
So I have two offices. I have one in Pennington, right at Hopewell Hospital, at Capitol Health in Hopewell, and the suite is 407. But I also see patients over in Newtown, Pennsylvania.
Over in where?
In
Town?
Newtown, Pennsylvania.
Newtown?
Mm-hmm. So either location.
Oh, yeah. Will you give me the contact information?
Oh, sure. You know what? I thought it was on one of the slides, but hold on. Let me get there. That way you don't have to worry about. Hold on. Here, I'll put
Thank
it
you.
up so you have it. Sorry. There it is. So it's the phone number is 609-303-4460, but I'll leave it up for you.
Thank you.
Oh, you're welcome. Are there any other questions?
Oh, so I just call this number for the appointment?
Yep, that's all you need to do.
Okay. Thank you.
Oh, you're welcome.
I'll have the
Okay. Any other questions for Kathie? Okay.
I see one here that, so if you're under the care of someone that and you don't feel like you're getting the results that you want, maybe you've tried a medication and it's not working. I always tell everyone that that if you're not moving, if they haven't offered you those other services like behavioral therapy or different medication or working with you, I'm more than happy to see you and send you back to your urologist. It's not that you have to leave that urologist. It's more so that to get those other services, we can work in conjunction with them. That's not a problem. And I would like to thank Barbara to reminding me that root beer does not have caffeine in it. But again, I still try to have people avoid sodas because of the carbonation, but it doesn't have caffeine in it. And so, again, at any point you can give us a call if you're interested to be seen and we can work with your urologist and work with those behavioral therapy if you need to. Any other questions? Oh, I did it again.
Okay, well, if not, thank you very much, Kathie. It was very informative. And just a reminder again to fill out the evaluation, and I will stay on until everybody finishes completing it.
All right, thank you everyone so much for taking your time tonight and spending it with me. Have a wonderful evening.
Thank you, you too.